Hi everyone, I'm Dr. Sakshi Arora Hans, your OB-GYN faculty at Marrow, and today I am here with you to discuss with you the NEET PG 2022 OB-GYN recall questions. Now, if you are watching this video, I'm sure you are not here just to know the correct answers or just to know the questions. You already know what questions were asked in NEET PG 2022 and you already know the correct answers to them. What you are looking over here is for the explanation to those questions and all important points related to that particular topic, because you know that it is not the question which is just important, it is that particular topic which becomes important from where the question was asked. Now, if you ask me about NEET PG 2022 paper about the OB-GYN part, it had a mixed bag of questions. There were questions which were very easy, there were questions which were tricky, and there were questions where you had to apply concepts. In spite of the detailed teaching which I do say that there were one or two questions which were not there directly from my notes. I think there were two questions, one on vesicovaginal fistula, which was not there directly from my notes, and there was one more question which was not directly from my notes, right? So I am going to tell you everything related to the important, not only the correct answer, but I'm also going to tell you the important points related to that particular topic. Now, in NEET PG 2022 and in INI CET, which happened in May 2022, PIH was a very important topic. On PIH, in NEET, there were 3 to 4 questions, and in INI CET, there were 2 questions. So for all of you, whether you are appearing for INI CET, whether you are appearing for NEET or for FMG, PIH becomes a very important topic. So the first question which I am going to discuss with you is related to the pathophysiology of PIH. Now, here the question is, a pregnant woman with no other comorbid condition develops pre-eclampsia. She inquires about the cause of a condition. The doctor explains that it is due to the failure of invasion of option A, spiral arteries by villus trophoblast, option B, radial arteries by cytotrophoblastic, option C, spiral arteries by extravillus trophoblast, and option D, arcuate artery by extravillus trophoblast. So, I have always taught you that cytotrophoblast is divided into 2 types. There is a villus cytotrophoblast and extravillus cytotrophoblast. Quickly tell me that what is the role of villus cytotrophoblast? Villus cytotrophoblast is the one which forms chorion frondosum, and because it forms chorion frondosum, it leads to the formation of the fetal side of the placenta. So the fetal side of the placenta is formed by chorion frondosum, which is a part of the villus trophoblast. Number 2, we have chorion levi. Chorion levi is also a part of villus cytotrophoblast, and this is the one which forms the fetal membrane chorion. And villus trophoblast has nothing to do with PIH, right? It is the extravillus trophoblast which plays a role in pathophysiology of PIH. So all your options where villus trophoblast is given, they are incorrect. So option A is ruled out. Now I have 2 options where extravillus trophoblast is given as an option and 1 option where only cytotrophoblast is given. Now coming to extravillus cytotrophoblast. Now this extravillus cytotrophoblast is further divided into 2 parts, the interstitial cytotrophoblast and endovascular cytotrophoblast. Now it is the endovascular cytotrophoblast. What it does is it replaces the lining of the spiral arteries and it converts them from high resistance vessels to low resistance vessels. All of you know that a placenta is made up of a number of villi-like structures, and in between them is the intervillus space. Now in the villi, it is the fetal blood which is going to enter, and in the intervillus space, it is the maternal spiral arteries which open. Now, these spiral arteries, they have got high resistance when they are initially opening into this intervillus space. And all of you also know this, that pressure and volume is inversely related. So if the resistance is high, the volume of blood coming into the intervillus space becomes low. So what this extravillus cytotrophoblast, specifically the endovascular cytotrophoblast, does is it replaces the lining of this spiral artery and it converts it from high resistance vessels into low resistance vessels. And this it is not going to do at one go. This it does in two stages. Initially, see over here we have a spiral artery which is present in the decidua part of the uterus, and we have a spiral artery which is also present in the myometrial segment. So when this cytotrophoblast is going to replace the lining of these spiral arteries, initially it is going to replace the lining of the decidual part of the spiral arteries, and this it is going to do by 12 weeks. And then between 12 to 16 weeks, it is going to replace the lining of the myometrial segment of the spiral arteries. And this is the way how, the low coiled and the high resistance narrow spiral arteries are finally getting converted into dilated vessels with low resistance. Can you see the difference over here? This is what is seen in a non-pregnant female, and this is what is seen during normal pregnancy. Now, what happens in PIH? In PIH, this entire process is called as vascular remodeling, or it is also called as trophoblastic invasion, right? Now, it is the maternal natural killer cells which help in this vascular remodeling. Now, what happens in patients who are going to have PIH? In them, this vascular remodeling is incomplete, or in other words, you can say that there is incomplete trophoblastic invasion. The decidual part of the spiral artery, the lining of the decidual part of the spiral artery, that gets replaced by the cytotrophoblast, the extravillous cytotrophoblast, but the myometrial segment, that remains not replaced. So that segment is unreplaced, right? So now, have you understood what is happening in PIH? So this is what I have written over here also, that this vascular remodeling, it converts the narrow lumen muscular spiral arteries into dilated low resistance vessels. In a pregnant female with PIH, the endovascular or the extravillous cytotrophoblast fails to remodel the myometrial segment of the spiral arteries. Now, because it is failing to remodel the myometrial segment of the spiral arteries, so the resistance will remain high. And obviously, if the resistance is going to remain high, the volume of blood which is going to enter into the intervillous space will decrease. And that is what is going to lead to placental ischemia. So this is the stage 1 of the pathophysiology of PIH, which is called as the placental syndrome. Now, imagine a placenta which is getting less blood from the mother, and there is placental ischemia because of which. Now, this placenta, it gets angry and it takes revenge from the mother. And how does it take revenge from the mother? It takes revenge from the mother by releasing inflammatory mediators into the maternal circulation, by decreasing vasodilators, and by increasing vasoconstrictors. Now, again, this is a very, very important question, that what are the vasoconstrictors which are decreased in a patient of PIH, and what are the vasodilators which are increased? So this also you have to remember, that thromboxane A2 is decreased, SFLT1, that is soluble FMS like tyrosine kinase, these are vasoconstrictors which are increased, and serum endoglin, these are 3 vasoconstrictors which are increased in a patient of PIH. Serum endoglin, SFLT1 and thromboxane A2. On the other hand, vasodilators like nitrous oxide, like vascular endothelial growth factor, placental growth factor, and prostacyclin I2. These are the ones which are decreased in case of PIH. A net result of all this is that there is leaking of the capillary endothelium. So if this over here is a capillary, this capillary is going to become leaky, and small tiny holes will be made in these capillaries. Now, from these tiny holes, the liquid component of the blood is going to come out, whereas the cellular component remains inside the capillaries, leading to hemoconcentration, stasis of the platelet, and platelet aggregation. Now, do these 3 terms raise some bell? Yes, this is what is Virchow's triad. So because now the Virchow's triad is getting activated, all this is going to lead to increased chances of thrombosis, and there is going to be thrombosis in blood vessels, and that is why there is multiple organ failure in a case of PIH. So PIH is not just restricted to increased BP, there is multiple organ dysfunction in a case of PIH. Now, because vasoconstrictors are increasing and vasodilators are decreasing. That is why the first manifestation which you get in a case of PIH is high BP. Have you all understood the pathophysiology? Very, very important. Now, based on this, I just want you to answer this MCQ for me now. Radial artery by cytotrophoblast, there is failure of invasion of radial artery by cytotrophoblast? No. Spiral artery by extravillous cytotrophoblast? Yes. Arcuate artery by extravillous cytotrophoblast? No. Right? So the correct answer is spiral artery. And what else are you going to remember? Which segment of the spiral artery? It is the myometrial segment of the spiral artery. And which type of extravillous trophoblast? It is the endovascular cytotrophoblast. Clear to all of you? Yes? Okay. Then, okay, the other thing, the way in which they can ask you this question is, they may also ask you, other than what are the vasoconstrictors which are decreased or what are the vasodilators which are increased, they may also ask you what are the predictors for PIH. So these are also the predictors for PIH. An increase in SFLT1, increase in serum endoglin levels, increased thromboxane A2, decreased prostacyclin I2, then your decreased nitric oxide, decreased placental growth factor and vascular endothelial growth factor, right? So these are also the predictors for PIH. There is one more predictor for PIH on which a question was also asked, and that is uterine artery Doppler. So let me first take you to that question, and then I'm going to come to the previous question. The question is, a woman with an obstetrical score of G2P1 comes to the clinic at 14 weeks of gestation for her antenatal checkup. A uterine artery Doppler was suggested by the doctor. What would it detect? Now, first and foremost, I am telling you that in OBS and Gynae, there are 3 Dopplers which you have to remember. Number 1 is a uterine artery Doppler. Now, whenever they are talking about uterine artery Doppler in OBS is done for predicting PIH. Although this is theoretical, clinically we don't use a uterine artery Doppler to predict that a female is going to develop PIH later on during that pregnancy. But then theoretically, yes, uterine artery Doppler has significance in predicting PIH. Number 1. Number 2, middle cerebral artery Doppler. Middle cerebral artery Doppler you are going to do whenever you have to detect fetal anemia. Now, whenever you have to detect fetal anemia, then you go for a middle cerebral artery Doppler, and in middle cerebral artery Doppler, you look at the peak systolic velocity. If peak systolic velocity is more than 1.5 mmol, then you say that there is fetal anemia. If it is less than 0.8 mmol, then you say that there is fetal polycythemia. Now tell me, in which conditions do you get fetal anemia? You get fetal anemia in case of RH incompatibility. You get fetal anemia in case of twin-to-twin transfusion syndrome, where one of the twin is going to have anemia, the other is going to have polycythemia, right? So in these conditions, I am going to do a middle cerebral artery Doppler. Third Doppler, which you have to know, is umbilical artery Doppler. Now, umbilical artery Doppler, it tells you about uteroplacental insufficiency. And you know that uteroplacental insufficiency will be seen in cases of PIH, and it can lead to IUGR. Obviously, what does uteroplacental insufficiency mean? It means that there is less blood coming to the placenta, and in turn, placenta is giving less blood to the fetus, right? And that is what is exactly happening in PIH. So, in case of PIH, there is uteroplacental insufficiency. So, whenever I want to look at uteroplacental insufficiency, I am going to go for umbilical artery Doppler. In other words, if I have to decide the prognosis of PIH, I am going to look at a umbilical artery Doppler. Similarly, for IUGR, I am going to go for umbilical artery Doppler. Right? Now, how is uterine artery Doppler helpful in predicting PIH? See, over here is the systolic phase of uterine artery Doppler, and this is the diastolic phase. And do you see over here a notch is present? Yes, this is what is called as a diastolic notch. Now, what happens in all vessels during pregnancy? See, during pregnancy, the major hormone is progesterone, and because progesterone is a smooth muscle relaxant, what is going to happen? It is going to decrease the peripheral vascular vascular resistance. And because it decreases the peripheral vascular resistance, the amount of blood flow during diastole is going to increase. Why it is going to increase during diastole? This is because during systole, the amount of blood which enters into an artery is not dependent upon its peripheral vascular resistance, because heart is actively contracting and sending blood. It is during diastole that the amount of blood which enters into a vessel, it depends upon how much resistance that vessel is offering. If that vessel is offering a larger amount of resistance, the amount of blood flow obviously is going to be less. Whereas if the vessel is offering less resistance, the amount of blood flow will be more. So, in a normal pregnancy, this notch, which is normally visible in a uterine artery Doppler by 20 to 22 weeks, it is going to disappear because the peripheral vascular resistance is going to decrease. Similarly, the pulsatility index of a uterine artery Doppler, it decreases as the pregnancy advances. Now, in case of PIH, what happens? In a patient of PIH, the vascular resistance is high because of these vasoconstrictors, and because the vascular resistance is high, now what is going to happen? The amount of blood which is entering into the uterine artery during diastole will be less, and there will be persistence of this diastolic notch. So, conventionally, we did uterine artery Doppler between 22 to 24 weeks, and if we saw that diastolic notch is persisting, then it indicated that this pregnant female in the later half of pregnancy is going to develop PIH. Although, as I told you earlier, this has only theoretical importance. It is not done clinically. Now, recently what they have shown is that you may not just do a uterine artery Doppler between 22 to 24 weeks. You can do it between 11 to 13 weeks as well. And when you do it between 11 to 13 weeks, you can, detect early onset preeclampsia. Right? So that is a predictor of early onset preeclampsia. What are you going to see between 11 to 13 weeks? You are going to look at the pulsatility index. And again, if the pulsatility index is high, that indicates that your patient is going to develop PIH. So if I ask you uterine artery Doppler, what all conditions can be predicted by uterine artery Doppler? It can predict PIH. In other words, it can predict preeclampsia. It can predict gestational hypertension. It can also predict chronic hypertension with superimposed preeclampsia, and it can also predict IUGR, right? So uterine artery Doppler theoretically can predict all these things. Clear? So over here, your question is, a woman with an obstetrical score G2P1 is coming to you at 14 weeks. A uterine artery Doppler was suggested by the doctor. What would it detect? Early onset preeclampsia, late onset preeclampsia, fetal growth restriction, placenta accreta. So it is going to help you in predicting or in detecting early onset preeclampsia. Although uterine artery Doppler can also detect or predict IUGR, but it is a better predictor of preeclampsia in comparison to IUGR. Right? So your answer is going to be early onset preeclampsia. Right? Now, your patient has got severe preeclampsia, and to prevent her from having convulsions, you have put her on magnesium sulfate. And that is a question which was again asked to you in your NEET PG 2022. A type 1 diabetic mother is on magnesium sulfate post-cesarean section for preeclampsia. She develops delirium and she is drowsy. She has a respiratory rate of 10 breaths per minute. Her random blood glucose level is 240 milligrams per dl. She has oliguria and bilaterally absent knee reflex. What is the cause of her condition? Now, there are options are magnesium sulfate toxicity, diabetic ketoacidosis, eclampsia, and diabetes insipidus. Now, number one, your question is saying she has PIH and patient is on magnesium sulfate. Right? Number two, your question is also saying that your patient is diabetic. So yes, either it can be a case of magnesium sulfate toxicity or it can be a case of diabetic ketoacidosis. Right? Why it cannot be eclampsia? Because they have not mentioned anything about generalized tonic-clonic convulsions. So obviously, eclampsia and diabetes insipidus are out of question. Now tell me, you have done much more medicine than what I have done. What do you get in diabetic ketoacidosis? In diabetic ketoacidosis is going to develop at much higher glucose levels than what are given over here. Over here, the glucose levels are 240. And diabetic ketoacidosis doesn't develop at glucose levels of 240. Although I want to point out to all of you that in a pregnant female, diabetic ketoacidosis is going to develop at a lower blood glucose level in comparison to any non-pregnant females, right? But then that lower blood glucose level is also 380 milligrams per dl. That is between 350 to 500 milligrams per dl. So number one thing which goes against diabetic ketoacidosis is the blood glucose levels. Number two, all of you know that in diabetic ketoacidosis, patient is going to come to you with nausea, vomiting, abdominal pain. She will be very, very thirsty, and there is going to be shortness of breath. There will be dyspnea, right, which is called as Cosmol's breathing. Never are you going to get respiratory rate depressed. Rather, there is shortness of breath. Rather, there is dyspnea in them, right? And you don't get bilaterally absent knee jerk in them, right? So again, diabetic ketoacidosis is ruled out because you are not getting any of the symptoms which are needed for making a diagnosis of diabetic ketoacidosis. Whereas on the other hand, you are getting all symptoms of magnesium sulfate toxicity. So coming to magnesium sulfate. Magnesium sulfate, again a question on magnesium sulfate was not only asked in NEET PG 2022, it was also asked in INI CET May 2022. Magnesium sulfate is an anticonvulsant which is used to control convulsions or prevent and treat convulsions. I shouldn't be saying controlling convulsions. Prevent and treat convulsions in a hypertensive pregnant female. But remember, magnesium sulfate is not an antihypertensive. It is a centrally acting drug which has got a very low therapeutic range between 4 to 7 milliequivalents per liter. What do you understand by this? This means that if magnesium sulfate is given and its dose is less than 4, your patient is going to continue to throw convulsions, and the moment the dose becomes more than 7, she starts showing symptoms of toxicity. So what are the signs and symptoms of magnesium sulfate toxicity? Number one symptom is loss of knee jerk. And this loss of knee jerk happens when magnesium concentration is more than equal to 10 milliequivalents per liter, right? Then a decreased respiratory rate, respiratory paralysis, and eventually leading to respiratory arrest. This is going to happen when magnesium concentration becomes more than equal to 12 milliequivalents per liter. Other symptoms which you get are diaphoresis, slurring of speech, and flushing. Then you can get cardiac conduction defects, which you are going to get when magnesium concentration is more than equal to 15 milliequivalents per liter. Now, please remember, oliguria, although whenever you are giving magnesium sulfate, we always tell you that you have to look for knee jerk, you have to look for respiratory rate, you have to look for urine output. But then oliguria is not a symptom of magnesium sulfate toxicity. It is not a symptom of magnesium sulfate toxicity. So now you're going to ask me that, ma'am, why do we look for urine output? We look for urine output because magnesium is basically excreted by the kidneys, right? So if there is oliguria, magnesium excretion is going to be less and it is going to lead to magnesium toxicity, right? But then oliguria is not a symptom of magnesium sulfate toxicity. Clear to all of you? Now, a few important points which I want you to remember more about magnesium sulfate is how to give magnesium sulfate according to the Pritchard regime. According to Pritchard regime, all of you know that you have to give a loading dose, and this loading dose will have IV component. The IV component is 4 grams IV 20% solution, and the IM component is 10 grams IV 50% solution. Now, when you are giving magnesium sulfate's loading dose, there is no need for measuring renal function. Now, whenever you are giving magnesium sulfate IV, an important thing which you have to remember is that the maximum flow rate at which you have to give is 1 grams per minute, right? That is maximum. In other words, when I have to give 4 grams of magnesium sulfate IV, I am going to give it slowly over 4 minutes, right? Ideally, you should give that dose over 15 minutes. But if you are in a hurry to give that dose, you should never give it ending at lesser than 4 minutes. Maximum flow rate which you have to give is 1 gram per minute, right? That is one very important thing. The other very important thing which you have to remember is that the magnesium sulfate ampule which is available in your labor rooms, that is a 2 ml ampule which has got 50% magnesium sulfate solution. Now this 50% magnesium sulfate means that 1 ampule of magnesium sulfate which is available in your labor room has 1 grams of magnesium sulfate. So it is a 2 ml ampule with 1 gram magnesium sulfate. So if I ask you that there is a patient who's throwing convulsions who has come to you, how many ampules are you going to pick up for the loading dose? So you have to give 4 grams as IV. So you're going to pick up 4 ampules for IV dose, and you have to give 10 grams as IM. So you're going to pick up 10 ampules for IM dose. In other words, a total of 14 ampules you are going to pick up whenever you have to give the loading dose of magnesium sulfate. That's one very important thing. The other very important thing is whenever you are giving IM dose, the IM dose is 50%, right? So this ampule is also 50% which is available in your labor room. So you don't have to make a solution equivalent to 20%, right? But in case of IV, you have to give 20%. So now you have to make a solution equivalent to 20%. How are you going to do that? For that, you are going to take a 20 ml syringe. And in this 20 ml syringe, you are going to put the 4 ampules of magnesium sulfate. When you put 4 ampules of magnesium sulfate, you are putting 8 ml of magnesium sulfate. In other words, you are putting 4 grams magnesium sulfate. Now, this 4 gram is just now a 50% solution. Right now, in order to make it a 20% solution, you are going to add 12 ml of normal saline. Right? So now in this 20 ml solution, there is 4 gram magnesium sulfate, and I am sure you know this much of maths that now there is 20% magnesium sulfate. So this solution, now you are going to give this to the patient as a loading IV dose, and please remember the maximum flow rate is going to be 1 gram per minute. Ideally, you should give it over 15 minutes. When it comes to the maintenance dose of magnesium sulfate is 5 grams IM, which is again a 50% solution which you have to give in alternate buttocks. And whenever you are going to give the maintenance dose, which has to be repeated after every 4 hourly. You know, magnesium sulfate, the maintenance dose has to be repeated every 4 hourly, and you have to continue magnesium sulfate till 24 hours after convulsions or till 24 hours after delivery, right? Till 24 hours after the last convulsion or till 24 hours after delivery, whichever happened later. So when you are giving the maintenance dose of magnesium sulfate, you have to be very careful that there is no pre-existing magnesium sulfate toxicity. And for that, you are going to check the urine output, which has to be at least 100 ml in 4 hours. Knee jerk should be present, and respiratory rate, it should be at least 12 breaths per minute. If any of these 3 things are not fulfilled, you are not going to give the maintenance dose. And remember, whenever there is magnesium sulfate toxicity, the antidote which you have to give is calcium gluconate. If calcium gluconate is not available, then you can also give calcium chloride. How much calcium gluconate? 1 gram IV of calcium gluconate. Right? So this is what you had to know about magnesium sulfate. Next question, which is again related to PIH, is a patient with normal BP, normal coagulation profile, has AST, ALT 75 international units, LDH 400, platelet count 75,000. What is your diagnosis? Now, over here in the options, they have given you cholestasis. Now, whenever they want you to make a diagnosis of cholestasis, one thing which they are definitely going to give you is serum bile acids. They are going to say that serum bile acids were increased. This is something which is missing over here, and that is why it cannot be a case of cholestasis of pregnancy. Over here, I am sharing with you on the screens a chart for the differential diagnosis of liver disorders during pregnancy. Once this session is over, I want you to come back to this session, just pause this video and copy this chart. This is a very, very useful chart and will help you in making, in coming to a diagnosis of various liver disorders in pregnancy. So in case of cholestasis, you should get increased bile acids, and this question is not telling you anything about increased bile acids. So, and the most common symptom symptom which you get in cholestasis is pruritus. Again, they haven't mentioned anything about pruritus, so this is not a case of cholestasis. Then again, it's not a case of hepatitis, because whenever there is hepatitis, the SGOT, SGPT, that is AST, ALT levels are not just mildly increased. They are very high. Right, so SGOT, SGPT levels are as high as 2000 international units, and serum bilirubin levels are also very high as 20. Right, that is why this is not a case of acute hepatitis also. Now comes the two important differential diagnoses. One is acute fatty liver of pregnancy and the other one is your HELLP syndrome. Now, if we talk about acute fatty liver of pregnancy, in acute fatty liver of pregnancy, patient presents to you with acute liver failure. And whenever there is acute liver failure, they are going to mention that the ammonia levels were increased, or they are going to say that the patient was having delirium, she was confused. Not only this, they are also going to mention hypoglycemia and decreased albumin levels. So if you are getting a picture where the liver enzymes are mildly elevated, but along with that you are getting decreased glucose levels, hypoglycemia, increased ammonia levels and decreased albumin levels, then you have to think about acute fatty liver of pregnancy. Or they may also say that patient had diabetes insipidus. Diabetes insipidus or pancreatitis. These are two complications which can develop in a patient with acute fatty liver of pregnancy. Not only this, in acute fatty liver of pregnancy, you are going to get the DIC markers. All of them will be deranged. So serum fibrinogen levels will be decreased. The fibrin degradation product will be increased. D-dimer levels will be increased. Prothrombin time will be increased. Right? So there is going to be acute fatty liver of pregnancy is one of the very important causes of DIC, right? So if you are getting a picture where you are getting DIC plus increased ammonia levels, decreased glucose levels, and you are getting mildly increased AST, ALT, serum bilirubin levels, that is the time when you should make a diagnosis of acute fatty liver of pregnancy. Now, in this question, they have not mentioned anything about ammonia, about hypoglycemia, about DIC. So I am going to consider it for HELLP syndrome. Now, in order to make a diagnosis of HELLP syndrome, the criteria which we are using is Tennessee's criteria. According to Tennessee's criteria, HELLP syndrome has H, which stands for hemolysis, and hemolysis should be diagnosed by any of the two things which I am going to tell you. Peripheral blood smear showing cystocytes, helmet cells or Burr cells, increased bilirubin levels to more than equal to 1.2, increased LDH levels more than equal to 2 times the normal value or more than 600 international units, decreased haptoglobin levels, that is to less than 25, and severe anemia unrelated to blood loss. If out of these 4, any 2 are present, then we say that your patient has hemolysis. EL stands for elevated liver enzymes, and elevated liver enzymes to more than 2 times the normal value. LP stands for low platelet count to less than 1 lakh. Now, in your question, you are getting LDH levels are high, or they are 400. Generally, we say that they are going to be more than 600 international units. But then during pregnancy, if they are more than 400, then also they are considered as high. Right? Then your platelet count is decreased. SGOT, SGPT, that is AST, ALT are increased. And so over here, normal coagulation profile. All this helps me in making a diagnosis of HELLP syndrome. Now, I'm sure you got confused. You are getting confused by this fact that this patient's BP is normal. Please remember that in 85% cases, HELLP syndrome is a complication of severe preeclampsia. But so many times I have made you write in your notebooks also, I make you write this specifically that in 15% cases of HELLP syndrome, BP of the patient will be normal. So here we have a patient whose BP is normal, but she's presenting to you as a case of HELLP syndrome. How do you manage HELLP syndrome? Whenever you get HELLP syndrome, the answer is you have to go for immediate termination of pregnancy. You are going to give a single shot of corticosteroid if gestational age is less than 34 weeks. You are not going to wait for 48 hours, and this is one of the changes which have come in Williams recently. Earlier, we used to say that if there is a case of HELLP syndrome, syndrome, which is coming at less than 34 weeks, you give them corticosteroid, you wait for 48 hours and then you terminate her pregnancy. But now it is said that if you are getting a case of HELLP syndrome, you have to give a single shot of corticosteroid. You don't have to wait for 48 hours and you have to go for immediate termination of pregnancy, right? So over here, this is the chart. I want all of you to copy this chart after the session is over. Next, a female patient presents to you with 6 weeks of amenorrhea associated with abdominal pain, vaginal bleeding with normal BP. So patient has come to you with amenorrhea, pain and vaginal bleeding. This is a case of early pregnancy bleeding. Investigation revealed beta HCG to be 1400 international units. Ultrasound scan was done which showed a trilaminar endometrium with normal adnexa. What is the next best step in the management of this patient? So whenever a patient is coming to you with amenorrhea of 4 to 6 weeks or 6 to 8 weeks, that is in first trimester, along with abdominal pain and vaginal bleeding, there are 3 differential diagnoses which you can have in your mind. Number 1, it could be a case of abortion. Number 2, it could be a case of ectopic pregnancy, or it can be a case of molar pregnancy. Now, molar pregnancy is very easily distinguished from abortion and ectopic pregnancy because whenever they are going to talk about molar pregnancy, they are going to say that the height of the uterus is more than the period of gestation. Then they are going to tell you that the levels of HCG were very high, and on ultrasound they are going to talk about snowstorm appearance. Now, since in the question nothing of this sort has been mentioned, so I am ruling out molar pregnancy. Now I have 2 differential diagnoses, that is abortion and ectopic pregnancy. Between abortion and ectopic pregnancy, remember that in case of abortion, bleeding is the most prominent symptom, right? Whereas in ectopic pregnancy, it is the pain which is the most prominent symptom. Now your question is further saying that although she has 6 weeks of amenorrhea, on ultrasound, they did not mention anything about seeing a gestational sac or any product of conception, right? In other words, the uterus is empty. So whenever you have a question which says that on ultrasound uterus is empty and beta HCG levels are positive or urine pregnancy test is positive, then please remember that is not diagnostic of ectopic pregnancy. Empty uterus doesn't mean it is diagnostic of ectopic pregnancy. It is only suggestive of ectopic pregnancy. And whenever you have such a finding, where you have a finding which is just suggestive of ectopic pregnancy and not diagnostic of ectopic pregnancy, the next step becomes beta HCG evaluation. So whenever you are in doubt, whenever uterus is empty and you have to see go for a next step, that in order to know whether you are dealing with a case of ectopic pregnancy, whether you are dealing with a case of abortion, or whether it is an early intrauterine pregnancy, your next step automatically becomes that you are going to do her beta HCG levels. So in this question also a beta HCG level was done. Now what do you have to look at beta HCG levels? You have to look at the discriminatory score. What is the discriminatory score? Discriminatory score is that value of beta HCG at which in an intrauterine pregnancy 100% cases, a gestational sac is visible. And this discriminatory score or the critical titer of HCG for TVS is 2000 international units, which means that whenever beta HCG values are 2000 international units or more than 2000 international units, and if you are getting an empty uterus, then you are confirmed that you are dealing with a case of ectopic pregnancy. But if the value is less than 2000, you cannot be sure that you are dealing with ectopic pregnancy. In your mind, you should have 3 differential diagnoses. Number 1, it could be that you are dealing with a case of live viable pregnancy, a viable intrauterine pregnancy, and a very early viable intrauterine pregnancy, or it could be a case of abortion, or it could be a case of ectopic pregnancy. How to differentiate between them? In order to differentiate between them, you are going to repeat HCG values after 48 hours. After 48 hours, if the values nearly double, and when I say nearly double, it means that the increase is somewhere between 33 to 66%, then you say that you are dealing with an early viable intrauterine pregnancy, right? And if values are high, but they increase, the values increase, but the increase is less than 33%. This is what is called as a slow rising value. A slow rising value is seen in case of ectopic pregnancy. But if after 48 hours the values decrease, then that means we are dealing with a case of abortion. Right? Now, if you've understood these concepts, now this question has become very easy for you. Question itself is saying that there was an empty uterus. They did not use the term empty uterus. Instead of using the term empty uterus, they are saying there is a trilaminar endometrium with normal adnexa. Right? So now, as I told you, whenever you are getting empty uterus, you should go and the beta HCG test is positive, urine pregnancy test was positive, any of them is given positive in the question. Next step becomes you have to check HCG levels, and this is already given to you. They have given you that the HCG levels are 1400 international units. Now, because HCG levels are less than discriminatory score, what is the next step? Next step becomes you have to repeat beta HCG after 48 hours. These are the types of questions which have started, they've started asking you what is the next step, what is the next step. And that is why I repeatedly tell you concepts are very, very important in OBGY. OBGY questions are very easy if you understand the concept. But if you try to mug up the answers or if you try to mug up anything which has been taught to you, then you will not be able to understand and you will not be able to answer what is the next step. Right? Coming to the next question, a female patient collapses soon after delivery. Again, this is one topic which is of interest in recent days. Postpartum collapse or postpartum shock. Recently, they have started asking many questions, whether it is FMG exam, your MCI screening exam, whether it is INI CET or whether it is NEET PG. This topic is again one of the newly emerging important topics. There is hypotensive hypoxia and features of disseminated intravascular coagulation. Which of the following is the most likely etiology? Now, before I start explaining to you this question, I want all of you to first tell and quickly revise with me what are the important obstetrical causes for DIC. Important obstetrical causes for DIC, number one is abruptio. That's the most common obstetrical cause for DIC. Number two, it is amniotic fluid embolism. Number three, it is intrauterine death of the fetus. And if the fetus is retained in the uterus for a period more than equal to 4 weeks, right? Number four, it is septic abortion. Right? Septic abortion. Number five, as I told you, it is acute fatty liver of pregnancy. And number six, yes, in 20% cases of HELLP syndrome, not in all cases, but in 20% cases of HELLP syndrome or in patients with severe preeclampsia and eclampsia, you may get DIC. But between AFLP and between HELLP syndrome, DIC is more common with AFLP and not with HELLP syndrome. Right? Okay, so over here I have listed down causes of DIC. This means that amongst all these causes which have the options which have been given to you, one cause is leading to DIC, a very prominently leading to DIC, and that is amniotic fluid embolism. Now, why am I saying that this amniotic fluid embolism is the correct answer here and why not the other options? See, amniotic fluid embolism I'm going to teach you in detail just now. Now, why it cannot be a case of postpartum hemorrhage? In postpartum hemorrhage, patient is going to have excessive bleeding and the chances of DIC are not that high. DIC, if at all, is going to develop, that is going to develop rarely and at a very late stage. Right? So it is not a case of postpartum hemorrhage. Peripartum cardiomyopathy. And again, in a patient of postpartum hemorrhage, there is not any cardiac failure. Question over here is talking about hypotensive hypoxia. In other words, they are saying there is heart failure. So in a case of PPH, you are not going to get heart failure. PPH, the most common cause is atonic uterus. Right? So you are not going to get heart failure and you are not going to get DIC. That's not the common presentation in PPH, right? Then comes peripartum cardiomyopathy. Peripartum cardiomyopathy mein patient is going to develop cardiac failure in the last month of pregnancy or within 5 months of delivery. There is absence of any identifiable cause of this heart failure. There is absence of any recognizable heart disease prior to the last month of pregnancy, and there is left ventricular systolic dysfunction. So definitely in peripartum cardiomyopathy, heart failure is there. But peripartum cardiomyopathy doesn't lead to DIC, and that is why this is not a case of peripartum cardiomyopathy. Then rupture uterus. Again, in rupture uterus, they are, rupture uterus is going to happen just at the time of delivery. It is, and you are going to get, typical features of rupture uterus, that there is going to be shock. The fetal parts are going to be palpable per-abdominally. There is going to be fetal death. Then there is going to be loss of fetal station. That is how a question is going to tell you whenever they want you to answer it as rupture uterus. So yes, it is not a case of rupture uterus as well. It is a typical case of amniotic fluid embolism. Now, in amniotic fluid embolism, it is a clinical diagnosis, and the diagnostic criteria for amniotic fluid embolism is patient is going to be having unexplained shock with very less vaginal bleeding. So, if your question is saying patient goes into unexplained shock and there is less vaginal bleeding, one thing which should come to your mind is amniotic fluid embolism. Then the clinical onset of amniotic fluid embolism occurs at the onset of labor or within 30 minutes of labor. There is abrupt cardiorespiratory arrest. You have to mark this word, respiratory arrest. Whenever you get a question which says that patient has difficulty in breathing, shock and less bleeding, and they ask you that the cause, that it has to be amniotic fluid embolism, this loss of respiratory difficulty or respiratory failure, these are the terms which are going to be used only with amniotic fluid embolism and not with any other condition. Then there is going to be overt DIC and no fever. So if you are getting any of these things, then we say it is a case of amniotic fluid embolism. Now in our case, we are getting that patient collapses soon after delivery. So yes, onset is happening when it happens in a case of amniotic fluid embolism. There is hypotensive hypoxia. So yes, there is cardiac arrest which is happening and features of DIC. So I'm going to take it as a case of amniotic fluid embolism. How are you going to know that you are dealing with a case of amniotic fluid embolism? What all things in the questions are going to tell you? Number one, if your question says patient goes into unexplained shock after delivery, your answer should be amniotic fluid embolism. Number two, if your question says patient has difficulty in breathing plus she has postpartum shock and less bleeding, then also you should think about amniotic fluid embolism. Or if your question says patient has shock and DIC, then also you should think about amniotic fluid embolism. In amniotic fluid embolism, there are two phases. In the first phase, patient is going to have cardiorespiratory arrest, right? So she's going to have features of cardiac failure and she's going to have respiratory failure. If patient survives that first phase, then she goes into the second phase, and in the second phase they have DIC. So initially in a case of amniotic fluid embolism, bleeding is less in the first phase. Bleeding is more when there is DIC, right? So don't say that, ma'am, in this question, because they are saying that there is bleeding. One of the recall questions, a few students said that in this question, ma'am, excessive bleeding was also mentioned, and that is why we did not mark the answer as amniotic fluid embolism. But you please remember that when DIC is going to happen in the second phase of amniotic fluid embolism, there is going to be excessive bleeding. In the first phase, there is less bleeding. Right? So based on bleeding, you are not going to say that I'm not taking it as a case of amniotic fluid embolism, because the term DIC was definitely given in your question. Clear? Now, about postpartum collapse, there is one more very important reason for a postpartum collapse, and that is uterine inversion. Now, whenever they are talking about uterine inversion, they are going to say that a patient goes into immediate shock after delivery. Why is there immediate shock in a case of uterine inversion? Because initially the shock which happens in a case of uterine inversion, it is neurogenic shock, right? And then later on, it is followed by hemorrhagic shock. But maternal mortality, which happens in a case of uterine inversion, is due to hemorrhagic shock. Another very important thing I want you to know is the difference in per-abdominal and per-vaginal findings in all these three cases. In a case of PPH, the per-abdominal finding will be atonic uterus. The tone of the uterus will be decreased. In a case of uterine inversion, you are going to get a cup-like depression just below the umbilicus. Whereas in a case of amniotic fluid embolism, everything will be normal. Per-abdominal examination will be absolutely normal. Similarly, think about per-vaginal examination findings. In a case of PPH, the per-vaginal examination finding which will be given to you will be that the patient is having excessive bleeding. In case of uterine inversion, when you will do a per-vaginal examination, you will feel some globular structure, that is the fundus of the uterus, will be felt inside the vagina. Whereas in case of amniotic fluid embolism, it is going to be absolutely normal because initially the bleeding is very less in amniotic fluid embolism. It is in the second phase of amniotic fluid embolism when DIC happens, when there is excessive bleeding. So per-vaginal examination findings are also normal in case of amniotic fluid embolism, right? So I hope you have now understood that how you are going to come to a diagnosis, whether it is amniotic fluid embolism, uterine inversion or postpartum hemorrhage. Now we have a very interesting question. While conducting a delivery, you perform the maneuver shown below. Following this, there is incomplete separation of the placenta and massive hemorrhage. So first tell me, what do you see in this image? You see that the placenta is being separated. With one hand, the person who's delivering is giving traction to the cord, and with the other hand, they are pushing the uterus up and back. And that is what is called as controlled cord traction. Now, there is incomplete separation of the placenta and there is massive hemorrhage. What is your next step? So please be very careful about these two words over here. There is incomplete separation of the placenta and massive hemorrhage. Now this means that it is a case where the placenta has not separated and patient is having bleeding because of this retained placenta. Now, whenever you have a question on retained placenta, first understand that what do you mean by a retained placenta? A retained placenta means that a placenta which is not delivered within 30 minutes of delivery of the fetus, right? Now, this retained placenta can fall into three categories. Number one, it can be a trapped placenta. A trapped placenta means that the placenta has separated from the uterus, but it is not expelled because the internal os is closed. And in this case, how do you know that the placenta has separated? Because signs of placental separation will be present. Now, whenever the signs of placental separation are present, the placenta has completely separated. What is the management? Management is you should empty the bladder of the patient and you should look at the tone of the uterus. If uterus is relaxed, in that case, you should give oxytocin so that the uterus contracts and it expels the placenta out. But if uterus is already contracted and the placenta is retained inside, it is separated and retained inside, then in that case, giving oxytocin is not going to help. In that case, you have to go for a manual removal of the placenta. On the other hand, it could be that the placenta is still attached to the uterus, or like in our question when they said that the placenta is incompletely separated, but it is not invading the myometrium. In other words, the placenta, it is not a case of placenta accreta. It is not a case of placenta accreta and the placenta has not separated or it is incompletely separated. In this case, the next step is that you have to give oxytocin. Plus, you have to do a controlled cord traction. Now, in the question which was given to you, already the controlled cord traction was being performed and still the placenta did not separate and patient was having heavy bleeding. So now in this case, just giving her oxytocin is not going to help now, because already controlled cord traction was being done. The placenta hasn't separated. It is incompletely separated and patient is having a lot of bleeding. So I have to go to the next step, and the next step is manual removal of placenta, right? Or it could be a case of placenta accreta spectrum, where they are going to tell you that the villi or the placenta is not getting separated from the uterus because it is attached to the myometrium. In that case, the answer is I have to perform immediately hysterectomy. Clear to all of you? Now, if during delivery of the placenta cord breaks and there is incomplete separation, again your answer becomes manual removal of the placenta. If the cord has broken, you are going to go for manual removal of the placenta. Manual removal of the placenta is done in OT. It is done under general anesthesia, or you may do it under regional anesthesia as well. You are going to give a single shot of antibiotic after the procedure, and you are not going to do a routine curettage after you have done manual removal of placenta, right? So whenever you have a case of retained placenta, see whether it is a case of trapped placenta or whether the placenta has not yet separated. If it is a case of trapped placenta, look at what findings they have given you. If they are saying uterus is relaxed, then your next step becomes oxytocin. If they say uterus is contracted, your next step becomes manual removal of placenta. If the placenta is incompletely separated or the placenta has not separated, in that case, the next step is controlled cord traction and oxytocin. But if the controlled cord traction was already done and still the placenta is not getting removed, then the next step becomes manual removal of placenta. Clear to all of you? Before I go to the next question, a very important thing is, what are the signs of placental separation? Number one, there is going to be a gush of blood. Number two, when the placenta is going to separate, it is going to fall into the lower uterine segment, and that is going to give a suprapubic bulge. The height of the uterus will slightly increase, which is called as the Schroeder's sign, and there is going to be apparent and permanent lengthening of the cord. So when the placenta was attached, cord was coming up till here. When the placenta is separated, definitely the cord is going to come up till here. That is apparent plus permanent lengthening of the cord, which is called as the Kushner's sign. If they ask you what is the best sign for placental separation, the best sign for placental separation is if you can feel the separated placenta in vagina, lying inside the vagina. But if that is not given, then Kushner's sign is the second best sign for placental separation. Clear? Now, the next question was related to pelvis. Identify the blue colored area shown in the image. So over here it is S1, S2, S3, S4, S5. The blue colored image is between S3 and S4. Now, first of all, you tell me, where does the pelvic inlet lie? Pelvic inlet, it lies at the level of pelvic brim. Where does the outlet lie? Outlet, it lies, the anatomical outlet, it lies at the level of ischial tuberosity. Right? And posteriorly, you have got the tip of coccyx. Right? So, inlet and outlet is not the answer. This is a case of mid-pelvis. The obstetrical outlet is also going to lie between, I'm going to just now tell you what is obstetrical outlet, but over here this is a case of mid-pelvis. Please understand that a true pelvis has three parts: inlet, cavity and an outlet. Inlet, anteriorly it is bounded by pubic symphysis, posteriorly it is bounded by sacral promontory, and laterally there is the iliopectineal line. Cavity, whenever we are talking about cavity, there are two planes with respect to which we talk about cavity, because cavity is, this over here is the sacrum, right? This is the sacral promontory and it is the inlet which is lying at the level of sacral promontory. This over here is the coccyx. The outlet is lying at the level of the coccyx. In between is going to lie the cavity. Right, so I cannot pinpoint that cavity is lying at the level of S1 or at the level of S2 or at the level of S3. Cavity is defined in terms of two planes. One is the plane of greatest pelvic dimension and the other one is the plane of least pelvic dimensions. Plane of greatest pelvic dimensions, it's anteriorly it is bounded by pubic symphysis, posteriorly it is bounded by junction of S2 and S3, and laterally it is bounded by the obturator foramen. Whereas the plane of least pelvic dimensions, it is bounded anteriorly by pubic symphysis only, posteriorly by junction of S4 and S5 vertebra, and then laterally it is bounded by ischial spine. Now, have you understood this? That plane of greatest pelvic dimensions, it is bounded anteriorly by pubic symphysis, posteriorly by S2, S3. So, posteriorly by the junction of S2, S3, right? And anteriorly by pubic symphysis and laterally by the obturator foramen. That is the plane of greatest pelvic dimensions. The plane of least pelvic dimensions, it is bounded by S4, S5, right? Posteriorly, anteriorly there is going to be pubic symphysis and laterally there is going to be ischial spine. Now in between them is mid-pelvis. So the roof of mid-pelvis is formed by the plane of greatest pelvic dimensions and the floor of mid-pelvis is formed by plane of least pelvic dimensions. So this over here is your mid-pelvis. Have you understood? Yes? Then comes your outlet, the anatomical outlet. Anatomical outlet is bounded anteriorly by the lower border of pubic symphysis, posteriorly by the tip of coccyx and laterally by ischial tuberosities. Whereas if we talk about obstetrical outlet, so first let me tell you where is the anatomical outlet. This over here is the anatomical outlet. Tip of coccyx, lower border of pubic symphysis and ischial tuberosities. Now, in between your plane of least pelvic dimensions and in between anatomical outlet, this area is your obstetrical outlet, right? So, this is the obstetrical outlet. So, over here, what they have shown you is the mid-pelvis. Please remember, outlets are going to be at the level of the tip of the coccyx. So posteriorly, in case of whether it is anatomical outlet, there is going to be tip of coccyx. And because obstetrical outlet is lying in between the plane of least pelvic dimensions and anatomical outlet, again in obstetrical outlet, posterior boundary is going to be either the junction of sacrum and coccyx, or you can say the tip of coccyx, right? So none of the outlets lie at the junction of S3, S4 or at the junction of S2, S3, what has been shown over here. Over here, the area which is marked is the area of mid-pelvis, which lies between the plane of greatest pelvic dimensions and plane of least pelvic dimensions. Remember, plane of greatest pelvic dimension, posterior boundary is junction of S2, S3 and plane of least pelvic dimensions, the posterior boundary is S4, S5. In case of plane of greatest pelvic dimensions, lateral boundary is obturator foramen. In case of plane of least pelvic dimensions, the lateral boundary is ischial spine. Why it is called as the plane of least pelvic dimensions? Because at this place, if you measure the transverse diameter of the plane of the least pelvic dimensions, that is the distance between two ischial spines, that is the narrowest diameter in the entire pelvis, measuring 10 centimeters, and that is called as the interischial diameter, or it is called as the bispinous diameter. The interischial or the bispinous diameter, that is the most important diameter in the pelvis because this is the smallest diameter in the entire pelvis. If fetal head can pass through this diameter, it can pass through any other diameter of the pelvis. Even so, obstetrical conjugate is between 10 to 10.5 centimeters. So the smallest diameter is interischial diameter or the bispinous diameter, which is 10 centimeters. Clear? So the answer over here was mid-pelvis. A primary gravida presents to the emergency room in early stages of labor with adequate uterine contractions. On pervaginal examination, a gynecoid pelvis is felt, the membranes are ruptured, vertex is felt in the right occipito-posterior position. How are you going to manage this? So, this question is saying that there is a gynecoid pelvis, membranes are ruptured and vertex is felt in right occipito-posterior position. So, first tell me what is the most common occipito-posterior position? That is right occipito-posterior position. Occipito-posterior position is a malposition which is more common in primary gravida females. Most common cause of occipito-posterior position is android pelvis. Second most common cause is deflexed head. Most common pelvis, if they ask you in which occipito-posterior position occurs, again your answer is android pelvis. In android pelvis, this is the only pelvis where ischial spines are very prominent, right? But in our patient, there is gynecoid pelvis. It is not a case of android pelvis. Most common pelvis in which you get a direct occipito-posterior position, that is anthropoid pelvis. Most common case in which you get a persistent occipito-posterior position, again, that's an anthropoid pelvis. Now, in an anthropoid pelvis, it is AP diameter which is more than transverse diameter. That's the only pelvis where this happens, right? So, whenever you are getting a direct occipito-posterior position in an anthropoid pelvis, then you can go for vaginal delivery, and that is called as a face to pubes delivery. Now, deep transverse, most common pelvis in which deep transverse arrest happens. Now, deep transverse arrest occurs at the level of ischial spine, and it happens in android pelvis. Right? Because in android pelvis, the ischial spines are very prominent. Now, if they ask you most common pelvis in which face presentation happens, I know this is out of context, but I wanted you to write it down that this is a platypilloid pelvis. Now coming to our question. Now our question is saying that you are conducting delivery and you are seeing that the occiput is in right occipito-posterior position. How are you going to manage it? Please remember that whenever there is occipito-posterior position, in 90% cases what happens, occipito-posterior position automatically is going to rotate by 3/8 of a circle. It is going to become occipito-anterior position, that is direct occipito-anterior position, and vaginal delivery will happen. The only thing what you have to do is have patience. You have to just wait and watch because the occiput has to rotate by 3/8 of a circle, so it is going to take a little more time, right? So I am not going to do anything. I am just going to wait for normal vaginal delivery. Patient is having adequate uterine contractions. I am not going to do anything. No cesarean section, no forceps, no vacuum. As it is. Forceps you are never going to do because forceps cannot rotate the head of the baby. So definitely it's not a forceps. It's not a cesarean section. There is no need for doing cesarean section. No need to apply vacuum. Just wait and watch and go for vaginal delivery. A very, very oftenly repeated question and a very, very simple question. Now, one more thing which they ask you in occipito-posterior position, which they might ask you in your upcoming NEET is, what are the per abdominal findings which you get whenever you have an occipito-posterior position? Please see over here, I have attached images of occipito-posterior and occipito-anterior position. In occipito-posterior position, you are going to get a subumbilical flattening. So if you see that the abdomen looks flat just below the umbilicus, that is one thing which should tell you or which should arise the suspicion of occipito-posterior position. Number 2, fetal limbs are very near to the umbilicus, whereas in case of occipito-anterior position, it is the back which is near to the umbilicus. In case of occipito-posterior position, the back of the baby is towards the flanks of the mother, and all of us know that fetal heart sounds are heard through the back. Now, in occipito-posterior position, it is the limbs which are closer to the umbilicus and back is towards the flank. So, fetal heart sounds are heard near the flank of the mother. Whereas in occipito-anterior positions, the back is towards the umbilicus, and that is why fetal heart sounds are heard near the umbilicus. So, these are very important features, per abdominal features, which can help in distinguishing between occipito-anterior and occipito-posterior position. Next question. You are examining a multigravida in the second stage of labor for past 2 hours. Multigravida female in second stage of labor for 2 hours. On examination, contractions are adequate, cervix is dilated, head is at 0 station with molding 2+, caput 2+, sagittal suture is in right occipito-transverse position. So here is where the sagittal suture of the head is. Fetal heart rate is normal. It is 140 beats per minute. Which of the following is carried out for management of this patient? First, tell me what is your diagnosis. See, the average duration for second stage in a primigravida female is 50 minutes and in a multiparous female it is 30 minutes. Now, if in a nulliparous females, maximum it can be for 2 hours according to ACOG, and in a multiparous it can be maximum for 1 hour. Arrest, the diagnosis of arrest is made if in a primigravida female, if the second stage becomes 3 hours, or in a multigravida female if it becomes 2 hours or more than 2 hours. This means our patient over here is a multigravida female who has been in second stage of labor for 2 hours, which means we are dealing with a case of second stage arrest. Now, this is what we have done till now, what ACOG recommends. Recently, WHO have updated all their guidelines, not only for related to first stage of labor, but also to second stage of labor. Now, WHO says that maximum duration of second stage is same as that that of arrest. Now, there is nothing like that the maximum duration is different and the diagnosis of arrest is different. No. According to ACOG, maximum duration was different and diagnosis of arrest was made after 1 hour of that maximum duration. But now WHO says that a maximum duration and that of arrest, it is same. That means according to WHO, maximum duration in a primigravida female can be 3 hours and that is also the diagnosis of arrest, and in a multigravida female it can be 2 hours and that is also the diagnosis of arrest. Now, whenever you have a question related to management of second stage disorders, I am telling you a simple trick of how are you going to recognize what is the next step. Now, if your question is saying anything about obstructed labor, how are they going to tell you that they are talking about obstructed labor? Because they are going to say a Bandel's ring was felt, or the mother was dehydrated, there was hot, dry vagina, the upper uterine segment was tensed, tender, whereas the lower uterine segment was relaxed. Now, if you are getting findings related to obstructed labor, in that case, if they ask you what is the next step, then your next step is you have to go for immediate cesarean section. There is no role of oxytocin. There is no role of wait and watch. There is no role of forceps or vacuum. Right? The moment you get hints related to obstructed labor, next step becomes emergency immediate cesarean section. Now, if your question says that there is slow progress of labor or there is arrest, slow progress of labor which was happening in the active stage, or if there is arrest along with caput and molding. Now, whenever there is slow progress of labor or an arrest along with caput and molding, then that means you are dealing with the case of cephalopelvic disproportion, and again your management becomes cesarean section. There is no role of oxytocin, no role of forceps or vacuum in a case of cephalopelvic disproportion. But if nothing like this is mentioned, your question is not talking about cephalopelvic disproportion, your question is not talking about obstructed labor. In that case, the next step is you have to check the station of fetal head. If station of fetal head is more than equal to +2, which means it is at the level of +2 or below the level of +2, in that case you are going to go for instrumental delivery. That is either forceps or vacuum. And if station is above +2, then you are going to go for cesarean section. Right, so in our question over here, they have mentioned that yes, there is second stage arrest, there is caput and there is molding. Right, so this means I am dealing with a case of cephalopelvic disproportion. Not only that, if you look at the station of fetal head is also 0. And just now I told you, you can apply instruments only if the station of fetal head is +2 or below that. So that means my answer is going to be a lower segment cesarean section. But just suppose that in your question, no caput and molding was given, and suppose in your question it was given that the station of fetal head is +2 and you had to choose. So now I am giving you a refined question, and that is +2 station, and they are saying the sagittal suture is in right occipito-transverse position, and they are also saying that there is no caput, no molding. And then if you had to choose the answer, how would have you decided that whether you are going to go for forceps delivery or whether you are going to go for vacuum delivery? Because if it is +2, there is no caput, there is no molding, you have to go for instrumental delivery. Now, in instrument, which instrument am I going to choose? How am I going to decide? So there are few common things which you have to remember about forceps and vacuum. Number one, both of them can be applied only when station is more than equal to +2. Number two, both of them should be applied only when the cervix is fully dilated, although vacuum can be used in incompletely dilated cervix when the cervix is more than equal to 6 centimeters. Then you may use vacuum. Ideally, you should use it when the cervix is fully dilated. A forceps can never be used if the cervix is not fully dilated. Right? Now, the other important difference between vacuum and forceps is vacuum can rotate the fetal head, whereas forceps cannot rotate the fetal head. Maximum sagittal suture, either sagittal suture of the fetus should be in AP diameter of the pelvis, or maximum it should be deflected by 45 degrees. In your question, they are saying that the sagittal suture is in occipito-transverse position. That means occipito-transverse position means that the deflection is is 90 degrees. So I cannot apply forceps. In that case, I would have had to apply vacuum. Clear to all of you? Now, a few more important things which you should remember. Now, if your question is talking about preterm delivery, or if they are talking about fetal distress, in preterm delivery, in fetal distress, you are going to use forceps, you are not going to use vacuum. Similarly, in breech, for delivery of after coming head of breech, forceps can be used. Forceps can also be applied to face presentation when there is mento-anterior face presentation. But in all these cases, you cannot use a vacuum. A vacuum cannot be used for preterm deliveries. A vacuum is not preferred in case of fetal distress. A vacuum cannot be applied to after coming head of breech, and it cannot be applied to a mento-anterior face presentation. Now, whether it is a vacuum, whether it is a forceps, both of them cannot be applied in all those conditions where you have to do a cesarean sections. What are those conditions where you have to do a cesarean section? In bro, transverse lie, in mento-posterior face presentation, and in obstructed labor and CPD. In these conditions, you have to do a cesarean section. You are never going to say that I'm going to use forceps or vacuum. So for face presentation, remember, forceps can be used for mento-anterior, but it cannot be used for mento-posterior. Vacuum can never be used in face presentation. Clear to all of you? Yes? So that is how you're going to answer all your questions related to second stage disorders. Now, a primary gravida presents to the labor room at 40 weeks of gestation with lower abdominal pain. She has been in labor for 3 hours. Which of the following will determine if she's in active labor? Now, all of you know that in the first stage of labor, there is a latent phase and there is an active phase. Now, according to WHO's recent guidelines, the latest guidelines of WHO, active phase begins at 5 centimeters. This is the most recent guideline where they say active phase begins at 5 centimeters. According to ACOG, active phase begins at 6 centimeters. Right? So over here, they have given more than 5 centimeters cervical dilatation with complete effacement. That is the answer for patient being in active labor. Now, why not? It is the other 3 options. Look at option A, which is saying fetal head 5/5 palpable on abdominal examination. So if this over here is the pelvis. Now, when do you say that the head of the fetus is engaged? Head of the fetus is engaged when it is less than 2/5, less than equal to 2/5 palpable per abdominally. Right? So if head of the baby is 2/5 or less than 2/5 palpable per abdominally, then you say head of the baby is engaged. Now, obviously, if it is 5/5 palpable on abdominal examination, the head of the baby is not engaged. But then, even if they would have given head 2/5, then also I wouldn't have said that this is a sign of active labor. This is because in primary gravida females, engagement happens before the onset of labor. In primary gravida female, engagement happens somewhere between 36 to 38 weeks of pregnancy. Whereas in multigravida females, engagement happens with the onset of labor. Right? And they are talking about active labor. So definitely engagement is not a sign of active labor. Number 1. Number 2 question they can ask you over here. If I ask you, suppose this question, what do you think is the most common cause of non-engaged fetal head in a primary gravida at term? And mostly you should get head of the baby engaged. But what is the most common cause that head of the baby is not engaged? Most common cause for this is a deflexed head. Please do not say it is cephalopelvic disproportion. It's a deflexed head. Or if deflexed head is not given, then say it is occipito-posterior position. Then comes the option B, 2 contractions lasting for 10 seconds in 10 minutes. So if there are 2 contractions which are happening in 10 seconds in 10 minutes, that again is not a sign of active labor. This is not even adequate uterine contractions. Adequate uterine contractions means if there are 3 contractions which are happening in 10 minutes, each lasting for 45 seconds and each increasing the intrauterine pressure by 45 to 65 millimeters of mercury. Then ruptured membranes. Ruptured membranes again is not a sign of active labor. This is because membranes can rupture before the onset of labor, that is what is PROM, or they can even rupture before 37 weeks, that is preterm premature rupture of membranes. So option A, B and D are incorrect. Option C is the correct answer. Next question, what will be the level of the uterus on second day post-delivery? Now please understand that immediately after delivery, the level of the uterus is at the level of umbilicus and it has a consistency of a cricket ball. Now this uterus, it doesn't start involuting immediately after delivery. After 24 hours, the uterus starts involuting and the rate of involution is 1 centimeter per day. That means 1 finger breadth per day. Now this is going to happen after 24 hours. Now your question is saying on the second day postpartum. On second day postpartum means after 24 hours. Now on second day, what has happened? On second day, the height of the uterus will be 1 finger breadth below the umbilicus. If your question would have said 48 hours after delivery, right, 2 days after delivery or 48 hours after delivery, then you would have said it is 2 finger breadth below the umbilicus. Your question is saying on second day postpartum. On second day postpartum, it is going to be 1 finger breadth below the umbilicus, right? After 1 week, uterus is midway between umbilicus and pubic symphysis and weight of the uterus is 500 grams. After 2 weeks, the uterus is not palpable and by 4 weeks, involution is complete. This all is given in Williams 26th edition, page 635, right? Then over here, I also want you to know that process of involution is due to decrease in size of the muscle fibers and not in the number. Involution is faster in nulliparous females in comparison to multiparous females, right? Coming to the next question, a primigravida woman at 12 weeks of gestation comes to the antenatal clinic for nutritional advice. Which of the following will you recommend? So over here, they have given additional 300 kilocalories in second trimester, additional 300 kilocalories in first trimester, additional 400 kilocalories in third trimester, additional 300 kilocalories throughout pregnancy. Now, all of you know that our national guidelines say that throughout pregnancy, an addition of 350 kilocalories is needed, right? This is what PARC says. This is what our national guidelines say. But then you also have to remember, how did they come to this value that 350 kilocalories is needed in pregnancy? They came to this value because they saw that if you are targeting a weight gain of 12 kgs in a woman during pregnancy, then in first trimester an additional of 85 kilocalories is needed, which is relatively negligible. Right? In second trimester, an additional of 280 kilocalories is needed, and in third trimester, an addition of 470 kilocalories is needed. And then they brought this average value that a 350 additional kilocalories is required throughout pregnancy. Right? Now, same thing has been recommended by Institute of Medicine. Institute of Medicine says that in first trimester, no additional kilocalories are needed. In second trimester, 350 kilocalories are needed. And in third trimester, 450 kilocalories are needed. I want all of you to remember this, that one plain thing, one simple thing, that our guidelines say 350 kilocalories throughout pregnancy, but most of the times you will not be able to answer questions based on this. In that case, you have to remember what our national guidelines say, that in first trimester it is negligible, around 85, in second trimester it is 280, and in third trimester it is 470 kilocalories. At the hindset, remember what your Institute of Medicine is also saying, which is roughly the same values as what our national guidelines say. So keeping this in mind, if I say additional 300 kilocalories in first trimester, that's wrong. Additional 300 kilocalories throughout pregnancy, that's wrong. Additional 400 kilocalories in third trimester, that's wrong. It is 450, or you can remember precisely 472 kilocalories. So that's also wrong. Additional 300 kilocalories in second trimester, yes, it is 280 kilocalories, which is roughly 300 kilocalories. So please remember what our national guidelines are saying, and also other than that, remember this is what Williams has said. Clear to all of you? Now, what is the total caloric intake which is required by a sedentary non-pregnant female? A sedentary non-pregnant female requires 1660 kilocalories per day. And then we are talking about additional kilocalories, right? Now, coming to the next question, a 40-year-old G2P1 woman with 18 weeks of amenorrhea comes with dilated cervix. Cervical length is 15 millimeters. In spite of explaining the risk, she insists on a cerclage. Which of the following is a contraindication for cervical cerclage? Now, as I had also explained to you in INI CET recall that cervical cerclage, many questions are being asked. And cervical cerclage you do for two purposes. Number one, in case of cervical incompetence, and number two, to prevent preterm labor. Now, in case of cervical incompetence, you can go for a history-based cerclage, you can go for ultrasound-based cerclage, or you can go for physical examination-based cerclage. What do you understand by these terms? History-based cerclage means that your patient has previous history of 2 second trimester abortions. So if your patient has history of 2 or more than 2 second trimester abortions and your patient is not pregnant just now, still you can go for a cerclage, and the kind of cerclage which you are going to do will be a laparoscopic cerclage. Now, if your patient has history of 2 second trimester abortions and your patient is presently pregnant, then you are going to go for McDonald cerclage. Now, the McDonald cerclage, or this cerclage which you are doing during pregnancy, you are going to do it between 14 to 20 weeks. The earliest time which you can do is 12 to 14 weeks. Please remember that whenever there is history of 2 second trimester abortions or more than 2 second trimester abortions, whether your patient is pregnant or non-pregnant, there is no need to measure her cervical length. You simply have to apply cerclage. The only thing which you have to keep in mind when you are answering questions related to history-based cerclage, your question says that there is history of 2 second trimester abortion and patient has come to you at 10 weeks. What is the next step? Then please don't say that at 10 weeks I'm going to do a cerclage surgery. No, you are going to say that I'm going to do a cerclage surgery between 12 to 14 weeks. And if they say that ultrasound is done in this at 12 to 14 weeks, no, there is no need to do any ultrasound at 12 to 14 weeks. Based on the history, straight away between 12 to 14 weeks, you can do the cerclage surgery, right? Okay. Then there is a second indication for doing cerclage in cervical incompetence, that is ultrasound-based cerclage. So suppose you have a question which says that there is a pregnant female who has come to you with history of 1 second trimester abortion, and they ask you what is the next step. Now, if there is history of 1 second trimester abortion, I am not going to put a cerclage straight away. For putting a cerclage straight away, I need history of 2 second trimester abortions. In this case, I am going to measure the length of the cervix, and if length of the cervix is less than equal to 2.5 centimeters, then I am going to go for a cerclage. And which cerclage is most commonly done? The McDonald cerclage. Again, the time is same, that I'm going to apply it between 14 to 24 weeks. Earliest I can do it between 12 to 14 weeks. Now, suppose your question says that there is a pregnant female who has come to you in second trimester and the cervix is already dilated. This is what is called as physical examination based cerclage, and this cerclage is called as rescue cerclage. Right? Now, normally the cerclage surgery is done up till 24 weeks. But RCOG says that if you are applying rescue cerclage, then you can do it up till 27 weeks. What are the contraindications for cerclage surgery? Now, there are absolute contraindications and there are relative contraindications. Absolute contraindications for a cerclage surgery are gross congenital anomalies in the fetus, number 1. Number 2, if membranes are ruptured. In other words, if there is a chorioamnionitis. Number 3, if there is a current pelvic infection. So these are the absolute contraindications for rescue for any kind of cerclage. Relative contraindication is placenta previa. Now, if your question is talking about preterm labor and your question says that there is a female who has history of 1 preterm labor, Generally, books say that this preterm labor should happen at less than 24 weeks. Some of them say that this preterm labor should happen at less than 28 weeks, right? So if there is history of early preterm labor, that is how they are going to mention to you. One history of early preterm labor, then in that case also you have to go for a cervical length measurement, and if length of the cervix becomes out to be less than equal to 2.5 centimeters and this patient has a singleton pregnancy, then we go for cerclage surgery. So in case of anticipated preterm labor, if there is a risk for preterm labor, and how do I come to know that there is a risk for preterm labor? Because patient already has previous history of preterm labor. So if your question says that there is previous history of preterm labor, now what is the next step? If there is previous history of preterm labor, the next step is you have to measure her cervical length. And along with that, if the cervical length comes out to be less than equal to 2.5 centimeters, you are going to apply cervical cerclage. Now, whenever you are applying cervical cerclage, whenever you apply cervical cerclage, please remember that along with cervical cerclage, you have to give progesterone. This is a thumb rule that when you apply cerclage, you also give progesterone. Now, I am just telling you two questions over here. Suppose your question says that there is a pregnant female with no history of preterm labor or no history of second trimester abortion, right? And an ultrasound was done, a routine ultrasound was done, and her length of the cervix comes out to be less than 2.5 centimeters. They ask you what is the next step. So please remember that if there is no history of preterm labor or no history of second trimester abortion, and if the length of the cervix is coming as less than equal to 2.5 centimeters, you are not going to apply cerclage, right? But then these patients, because of the short cervix, they have high risk of preterm labor, and that is why my next step becomes only progesterone. Don't say I'm going to apply cervical cerclage. Similarly, they may ask you a question that there is a pregnant female with history of one preterm labor or history of one second trimester abortion. And when you did ultrasound, on ultrasound, cervical length is more than 2.5 centimeters. And they ask you what is the next step. Now, because again, there is history of preterm labor or there is history of second trimester abortion, but the length of the cervix is more than 2.5 centimeters, you cannot say that the next step is cervical cerclage. But still, these patients are at high risk of either cervical incompetence or preterm labor. So now again, my next step is progesterone. Whenever I see my patient has a risk of preterm labor, I have to give them progesterone, or if I see my patient has risk of the cervix getting dilated, uterine activity happening, I am going to give her progesterone, right? So in these two cases, do not say that you are going to do a cerclage surgery, just say that I am going to give progesterone. And whenever you do a cerclage surgery, don't forget to say that I'm also going to give progesterone. Till when are you going to continue progesterone? You are going to continue progesterone till 36 weeks. At what time do you remove the cerclage stitch? The stitch of the cerclage that is removed at 37 weeks. And you are going to remove it irrespective of the gestational age, if there is fetal distress or if chorioamnionitis develops or if the membranes rupture or if patient goes into preterm labor. Then in those cases, you are going to, irrespective of the gestational age, you will have to remove the stitch. Clear? Coming to the next question, a pregnant patient with history of classical cesarean section in view of fetal growth retardation in previous pregnancy presents to you. She is currently at 35 weeks of gestation with breech presentation. What is the next step? So that was again a very simple question. If you have a case of classical cesarean section, which means that the incision was given in the upper uterine segment, the chances of uterine rupture are high in the next pregnancy. So in next pregnancy, VBAC is absolutely contraindicated. What is VBAC? That is vaginal birth after cesarean, which is also called as TULAC, trial of labor after cesarean. And the next step is you have to go for a cesarean, repeat cesarean section. Whereas if it is a case of lower segment cesarean section, the chances of rupture are very less, and that is why in case of lower segment cesarean section, you can try a VBAC in the next pregnancy. Now, please remember that whenever we are talking about incisions, these incisions are uterine incisions which we are talking about. We are not talking about skin incisions. If you are giving an incision in the upper uterine segment, the name of that incision is Sanger's incision and the cesarean section is called as classical cesarean section. Chances of rupture are 2 to 9%. Similarly, if you've given a T-shaped incision, with a T-shaped incision also VBAC is absolutely contraindicated. But if you have done a lower segment cesarean section where you have given a low transverse incision on the uterus, that is what is called as a Kerr's incision, the chances of rupture are 0.2 to 0.9%, and in this case you can go for a VBAC. Please remember, the chances are 0.2 to 0.9% only if there is history of 1 LSCS. The moment this becomes 2 LSCS, the chances of rupture double, and that is 0.9 to 1.8. Now, sometimes, rarely, we may give a vertical incision in the lower uterine segment, although that is also called as LSCS, but the name of that incision is a chronic incision, and the chances of rupture with a chronic incision are 1 to 7%. Now, ACOG recommends that most women with one prior low transverse cesarean section, they are the ideal candidates for undergoing 2 lakh. Home birth is a contraindication for 2 lakh. If you are trying vaginal delivery after cesarean section, it has to be an institutional delivery. Prior classical T-shaped incision or a classical incision or a T-shaped incision are an absolute contraindication for 2 lakh. Prior history of uterine rupture is an absolute contraindication for 2 lakh. Relative contraindication for VBAC or 2 lakh is macrosomia in present pregnancy and malpresentation in present pregnancy. So if there is breach in present pregnancy and there is previous history of cesarean section, that's a relative contraindication for doing a VBAC. The new recommendation of ACOG is, earlier it was saying that a chronic incision is an absolute contraindication for doing a VBAC. Recently, ACOG has said that a previous chronic incision is not an absolute contraindication for VBAC or 2 lakh. Then, a version can be attempted in breach with previous cesarean section. So, till now they were saying that external cephalic version is a relative contraindication in previous cesarean section patients. But now ACOG has said that no, external cephalic version is not a contraindication in a breech presentation if there is previous history of cesarean section. That's an update. Then twins in present pregnancy is not a contraindication for 2 lakh or VBAC. Right? So that is again very important. VBAC or 2 lakh is again an important topic. Your concepts should be absolutely crystal clear about it. These all points are from Williams 26th edition. So note down these points and keep revising them. So over here in your case, they are saying a patient has previous history of classical cesarean section. She has come to you at 35 weeks of gestation with breech presentation. What are you going to do? Cesarean section at 37 weeks, advise ultrasound and visit after 2 weeks, internal podalic version followed by vaginal delivery. See, internal podalic version is, there is only one indication for internal podalic version, and that is second twin transverse lie. External cephalic version at 36 weeks, no. Nothing of this sort I'm going to do because it is a case of classical cesarean section. Classical cesarean section means that I have to do a repeat cesarean section. So I'm going to call her at 37 weeks and I'm going to do a repeat cesarean section. Right? Then a primigravida at 22 weeks of gestation presents to you with profuse vaginal bleeding. Her blood pressure and glucose levels are within normal limits. Placental implantation at which of the following sites can cause this? Now, if it is a case of abdominal ectopic or if it is a case of ovarian ectopic, you are never going to get the symptom profuse vaginal bleeding at 22 weeks, number one. So, ovarian and abdominal ectopic ruled out. You don't get profuse vaginal bleeding, you get a hemoperitoneum. In case of ectopic pregnancy which is happening in the fallopian tubes, it is never going to present to you or it is never going to persist till 22 weeks. Right? Hardly it goes beyond 10 to 12 weeks. So it cannot be at the level of fallopian tube. So yes, here the placental implantation is happening at the level of internal os, and that is why patient is having vaginal bleeding. Right? Then comes identify the type of hymen shown in the image. That's a very easy question. Over here, what you are seeing that the hymen has a septa in between. Can you see the septa in between? So it is a case of septate hymen. Now in hymen, if normally there is a small opening through which menstrual blood comes out, and if this opening is absent, that is what is imperforate hymen. This is not a case of imperforate hymen because I can see the openings. Then it is not a case of annular hymen. Annular hymen means that a round opening is present. Over here, definitely I can see a septa. Then what is a cribiform hymen? A cribiform hymen is a one in which you have got multiple small openings. That is a cribriform or a sieve-like hymen, right? So this is a case of septate hymen. Coming to the next question, while discharging a patient who underwent vesicovaginal fistula repair, which of the following would you recommend? Now, whenever you do a vesicovaginal fistula repair, please remember that for 2 weeks, you are going to do continuous bladder drainage. You are going to do a continuous bladder drainage for at least 2 months. You are going to ask them to practice abstinence, and pregnancy is avoided for 1 year, right? So over here they are saying sexual abstinence for 3 months and avoid pregnancy for a year. That is the most appropriate answer, because the other options say avoid pregnancy for 6 months. That's wrong. Sexual abstinence for 6 weeks and avoid pregnancy for a year. Again, that's wrong, because it has to be at least 2 months. Right? Sexual abstinence for 6 months and avoid pregnancy for 6 years. That's wrong. The textbooks say that it has to be at least 2 months and ideally it has to be 6 months of abstinence. So 3 to 6 months is the best time. At least, 2 months or between 3 to 6 months is the abstinence which is needed. If the couple cannot abstain for 3 to 6 months, then at least 2 months they have to abstain, and pregnancy is contraindicated for at least 1 year after a repair of vesicovaginal fistula. Clear? Now, a 20-year-old woman is evaluated for primary infertility. HSG was done and it reveals the findings shown below. What is the anomaly seen in the image? Now, this is how, Mullerian anomalies are detected. Either a Mullerian anomaly is detected when a female comes to you with complaint of recurrent abortions and you do an ultrasound. So, on ultrasound, an incidental finding could be a Mullerian malformation, or the patient is coming to you with infertility and you do an HSG. Right? And then an incidental finding is Mullerian malformation. So Mullerian malformations are usually diagnosed incidentally either on HSG or on ultrasound. Now, an HSG is not a very good tool for recognizing the Mullerian anomalies. Right? But still they keep on asking you questions related to, they give you HSG images and they ask you which Mullerian anomaly it is. Now, whenever you get a question where you have to identify which Mullerian anomaly it is based on HSG, the first thing which I want you to see is the number of fallopian tubes. Because if you are getting a single fallopian tube, then that means you are dealing with a unicornuate uterus. So if you are getting a single fallopian tube plus a banana-shaped uterus, then that means it's a case of unicornuate uterus. Now, if the number of fallopian tubes are 2, then what you have to do next, this is the first step. Then second step, what you do is you look at the number of HSG cannulas. Because if you are seeing in your image 2 HSG cannulas, then that means you are dealing with a case of uterus didelphus. Right? But if you are seeing a single cannula, then what you have to do? Then you have to look at the, there are 2 uterine horns. You will see 2 uterine horns. You will see a single cannula, 2 uterine horns, and you will see 2 fallopian tubes. You will see a single vagina. Right? Now, if this is the situation where there is a single vagina, there are 2 uterine horns and 2 fallopian tubes. Now, I have to know whether I'm dealing with septate uterus or biconnuate uterus. In that case, you have to look at the angle between the horns. If the angle between the horns is acute and the distance between them is less than 4 centimeters, then that means you are dealing with septate uterus. But if angle between the horns is obtuse and the distance is more than equal to 4 centimeters, then you are dealing with a bicornuate uterus. Please remember difference between bicornuate and didelphic uteruses. In uterus didelphus, there are 2 vaginas. That is why 2 cannulas are used. Whereas in a bicornuate uterus, there is a single vagina. In a septate uterus, there is a single vagina, so a single cannula is used. So keeping this algorithm in mind, let us make the diagnosis here. Here you can see that there is one fallopian tube and there is another fallopian tube. Right? Because I can see 2 fallopian tubes, it is not a case of unicornuate uterus, and there are 2 uterine horns I am seeing. So if I am seeing 2 uterine horns, it cannot be a case of unicornuate uterus. Now look at the number of the cannulas. It is a single cannula. If it is a single cannula, it cannot be uterus didelphus. So either I am looking at a septate uterus or bicornuate uterus. Now look at the angle between them. The angle between them is appearing acute and the distance between them is appearing less than 4 centimeters. That means I am dealing with a case of septate uterus. Another very important thing which you should remember is that in case of septate uterus, if you will see the fundus of the uterus will be absolutely normal. So if you are getting diagrams or illustrations, right, in illustrations, if you see that the fundus of the uterus is absolutely normal, undivided, then that means the image or the diagram is of septate uterus. But if you see that the fundus of the uterus is divided like this, then it means you are dealing with a bicornuate uterus. Generally, in Mullerian malformations, these are the questions which they ask you. They are going to give you spotters and you will have to identify which type of uterus you are looking at, right? Then, testosterone helps in development of various organs in the fetus. Which of the following is the first stimulus for its production? A very, very easy question because this is something which we do so many times in class. I tell you that in males, how does the hypothalamic pituitary testicular axis function? Hypothalamus releases GnRH, which acts on anterior pituitary to release FSH and LH. FSH acts on the Sertoli cells. From Sertoli cells, inhibin is released, and whenever inhibin is released, whether in males or females, it has a negative feedback on FSH. LH acts on the Leydig cells and LH produces testosterone in intrauterine life from the Leydig cells. Testosterone production in males begins at 8 weeks and is maximum by 15 weeks, and it is this testosterone in intrauterine life which is responsible for growth of Wolffian duct, and it leads to the formation of male internal genital organs, that is SEED. What is SEED? SEED stands for seminal vesicles, epididymis, ejaculatory duct and vas deferens. This testosterone which is released in intrauterine life is also responsible for scrotal descent of the testes. This testosterone will have a negative feedback on GnRH, and this testosterone will get converted into dihydrotestosterone, which is responsible for making the external genitalia look like male external genitalia. So this testosterone which is being released by the Leydig cells under the influence of LH is very important. But then this testosterone is the initial stimulus for the Leydig cells to release testosterone is not LH. The initial stimulus is HCG. Right? So, and that is what they are asking you, which is the first stimulus or the initial stimulus. The first stimulus or the initial stimulus is HCG from the placenta, and it is not LH. Have you understood this? So your answer is going to be HCG. Clear? A 24-year-old lactating woman with 18 months child comes with history of irregular heavy bleeding seeking contraceptive advice. What is the contraceptive of choice? So number one, she is lactating, but then she has an 18 months old child. Number two, she has irregular heavy bleeding. So keeping these two things in mind, I have to choose a contraceptive which doesn't lead to heavy bleeding, which doesn't lead to irregular bleeding, rather helps in curing it. Right? So obviously, Copper T 380A is out of question because copper T leads to increased bleeding, so I'm not going to use it. Number 2, Progestasert is out of question because Progestasert, which is a progesterone IUCD that is not available now, that is not being used anywhere. Instead of Progestasert, now what is available in the market is Mirena. And because they had given Progestasert in the options, you are not going to say that I'm going to use Progestasert. Right? Now the choice is between Mala-N and norethistron enanthate, the depot injection. Now norethistron enanthate is a progesterone injection which has to be repeated every 2 monthly. Now before I tell you that why am I choosing one over the other, please understand that in a female who is lactating or whether it is exclusive breastfeeding or partial breastfeeding, when do you start a contraceptive and what contraceptives do you start at various times? A clear understanding of this is very, very important. Now, in a female who's not breastfeeding or who's partially breastfeeding, you have to start a contraceptive by 3 weeks, and if a female is completely or exclusively breastfeeding, then you have to start a contraceptive method by 3 months. Right? Now, in the postpartum period, there are certain contraceptives which can be started from day 1. For example, condoms. A male condom can be used from day 1 after delivery. IUCD insertion can be done within 48 hours of delivery, which is called as postpartum IUCD insertion. And if it is done within 10 minutes of placental delivery, that is what is called as post-placental insertion. But if it is not done within 48 hours, then you have to wait for 6 weeks, and that is what is called as interval insertion. Right? So postpartum insertion and interval insertion. So IUCD can be inserted in a breastfeeding female. It can be inserted in a non-breastfeeding female. That is copper IUCD I'm talking about. Right? Then comes mini laparotomy. Mini laparotomy, if you are doing tubectomy by mini laparotomy. Tubectomy by laparoscopic method is not done in the postpartum period. But yes, by mini laparotomy, you can do it till 1 week after delivery, which is called as postpartum sterilization. And if you do not do it within 1 week after delivery, then you have to wait till 6 weeks, which is called as interval sterilization. Emergency contraceptive can be used by a postpartum female at more than equal to 4 weeks. And Centroman, which is a non-steroidal hormonal contraceptive that can be used from day 1, whether she is breastfeeding or whether she is not breastfeeding. Right? Then, when we are talking about steroidal contraceptives like estrogen and progesterone containing contraceptives, I have 2 concerns. Number 1, estrogen which is present in an oral combined pill, it decreases breast milk. Number 2, estrogen also increases clotting factors, and because it increases clotting factors, that is why there is increased risk of venous thromboembolism. Right? Because of this reason, estrogen and progesterone are not used in immediate postpartum period. But then progesterone-only contraceptives don't have this kind of a disadvantage, so they can be used in the postpartum period. Keeping these things in mind, if I ask you, when can you use oral combined pills in a fully breastfeeding female? In a fully breastfeeding female, oral combined pills are absolutely contraindicated at less than equal to 6 weeks. And ideally, if you want to start them, you should start them at more than equal to 6 months. Absolute contraindication is at less than equal to 6 weeks. But ideally, you should start them after 6 months and not before that. In a partially breastfeeding female, they are absolutely contraindicated at less than equal to 3 weeks. Ideally, you should start them after 6 weeks. Progesterone-only contraceptives are not contraindicated whether a female is breastfeeding or not. Similarly, progesterone implants are not contraindicated whether a female is breastfeeding or not. As far as DMPA injection is concerned, DMPA injection is not going to have any problem with clotting factors. It is not going to have any problem with, breast milk also. But the problem which DMPA injection has is it decreases bone mineral density. And that is why in a lactating female, it is contraindicated till 6 weeks after delivery. In a non-lactating female, it is not contraindicated, right? So keeping this in mind, now you have a female who has 18 months old child. This female is eligible for oral combined pills also, and she is eligible for this progesterone injection, that is norethistron enanthate also. Now I am going to choose Mala-N over norethistron enanthate. This is because one of the complications of norethistron enanthate is irregular bleeding. Right? So, and number 2, like Depo-Provera, it leads to a decrease in bone mineral density. Norethistron enanthate has not been studied that greatly. That might also decrease bone mineral density. As it is, she is feeding her baby till 18 months. And then on top of that, I advise her norethistron enanthate. That I'm not going to do. Right? So, if I have to choose an answer, I'm going to go for Mala N in this case, because when you give oral combined pills, as it is, if your question anytime says that there is irregular bleeding, irregular cycles. For irregular cycles, the drug of choice is oral combined pills, right? And over here, patient is lactating for 18 months. So there is no problem in giving oral combined pills. So the answer over here is definitely Mala and no ifs, no buts here. Which of the following is an absolute contraindication for the insertion of device shown to you in image below? So what is this? This is copper T 380A. And what is an absolute contraindication? Menstruation. Is menstruation an absolute contraindication? No. Immediately after delivery? No. Just now I told you that there is a post-placental insertion and postpartum insertion. Ruptured condom during intercourse? No. Rather, copper T 380A or copper T for that matter is the most effective emergency contraceptive, and it can be used up till 5 days of unprotected intercourse. Right? So by exclusion, my answer is trophoblastic disease as well. Now, whenever there is a trophoblastic disease and you've done a molar evacuation, suction evacuation of a molar pregnancy, the contraceptive of choice is oral combined pills. Reason being, if you are giving a copper T, if you are inserting copper T, number one, in a molar pregnancy, the uterus was very, very soft. So if you insert a copper T, there are slightly increased chances of uterine perforation. Number one, that's a slightly increased risk. Number 2 reason why I'm not giving copper T is because copper T itself leads to bleeding, right? And now if my patient in whom I have done suction evacuation after a molar pregnancy, if she bleeds, bleeding is one of the important signs of a development of gestational trophoblastic neoplasia. Now, if I have inserted copper T, I will not be able to know whether my patient is bleeding because she has developed GTN or she has developed her bleeding because of copper T. That is why we do not prescribe copper T after suction evacuation of a molar pregnancy. We go for oral combined pills, right? What are the absolute contraindications for copper T? If there is current PID, if there is undiagnosed vaginal bleeding, distorted uterine cavity, which can happen like in case of cancer cervix, cancer endometrium, or in case of suspected pregnancy. Please remember, previous history of ectopic pregnancy is not a contraindication for IUCD insertion. Next question. A 20-year-old, and I think this is the last question, a 20-year-old woman presented at 7 weeks of gestation, unwilling to continue her pregnancy. What drugs are going to be used for medical termination? That's very easy. For medical abortion, there are 2 drugs which are being used. One is mifepristone. Mifepristone, which you have to give, is 200 milligrams, single tablet, which you have to give orally. And then after 48 hours, you have to give mesoprost. Now, mesoprost, which you have to give 400 micrograms, and this mesoprost, it can be given orally, sublingually, or per vaginally. Any way you can give mesoprost, right? This is when you are doing medical abortion up till 7 weeks, and this is what is recommended by Government of India. In India, medical abortion is done up till 7 weeks, and it is done as an OPD procedure. But then WHO recommends medical abortion up till 9 weeks. So up till 7 weeks, WHO follows the same protocol what we follow in India. Between 7 to 9 weeks, WHO says if you are doing medical abortion, mifepristone tablet dose remains the same. It is the mesoprost tablet which changes. At 9 weeks, mesoprost becomes 800 micrograms. And another difference which comes when you are doing medical abortion between 7 to 9 weeks, you have to admit the patient. You have to do it as an IPD procedure. Now, whether you are doing medical abortion up till 7 weeks or between 7 to 9 weeks, in either case, on day 15, you are going to call them to evaluate that the medical abortion is complete. Now, whenever you have to evaluate whether medical abortion is complete, it is not mandatory you do an ultrasound. If your patient is giving you history that the bleeding happened and then the bleeding stopped, now there is no more bleeding, no spotting, nothing, then it is not necessary to do an ultrasound. Only if you are suspecting that a retained product might be left, then you are going to go for ultrasound. Right? So that's all what I wanted you to know for as far as NEET OBGY recall questions of 2022 was concerned. I know this was a little lengthier session than I had also expected, but then I wanted to cover all the important points related to that particular question. So all the best for your upcoming NEET exam. Take care. Bye-bye.